Okay, we'll get started.
Yes, please. Thank you.
Okay. Today's talk is about perioperative coagulation management, and again, the issues I'm going to kind of point to are also how we're thinking about coagulation issues. Remember, coagulation is not simply just the coagulation cascade. It is also about discussion of platelet function and how we work with platelets as well. We'll get into that. Next slide. Remember, when you're talking about hemostasis, really we're talking about four issues, right? Vascular constriction, which automatically takes place when the blood vessel is cut by the surgeon. We start getting platelet plug formation, then we talk about fibrin formation, and then we talk about fibrinolysis. Now, remember, if at any point any of these processes become problematic, we have to be very careful about how we think about these things. And fibrinolysis can run out of control in a lot of our patients. So we have to pay close attention and really kind of think about how we're going to deal with this. Okay, next slide. I'm going to show you guys some drawings because I think it's better if it's a visual that you guys can see. I'm sorry about the artwork, but it's actually the best way to understand what's going on. But I do want you guys to see that the vascular endothelium, when it's damaged by surgery or by trauma or by anything, first thing that happens is platelets are involved with the initial plugging, right? That takes place, and that plugging takes place as again. The platelets are anchored to the subendothelial collagen, so that's how that works. And we'll talk about this as we go. Next slide. Now you can see here that as the blood vessels are damaged, and the exposure of the subendothelial collagen is there. Next slide. I'll show you the picture. Okay. The platelets attach to the subendothelial collagen. Now the subendothelial collagen is attached via von Willebrand's factor. That's factor 8 von Willebrand's. Now factor 8 von Willebrand's, remember, is produced and released by the endothelial cells, not by the liver. So we want to make sure that von Willebrand's factor is there and it's working. And how do we do that? Well, we can give DDAVP, or we can give cryoprecipitate to make sure we have enough von Willebrand's factor if there's a shortage. So again, something to think about when we're talking about transfusion of blood products. We have to be thinking about cryo, not necessarily FFP alone. And this is something that's a mistake that's made by a lot of novices, is they don't think about von Willebrand's factor, they don't think about fibrinogen, and I'll get into fibrinogen in just a second. But fibrinogen is a major issue for us, and in fact, the changes that I've noted over the last 5 years have brought out the issue that even moderate drop in fibrinogen level can lead to extremely excessive bleeding issues. So we have to think about that. Next slide. Okay, so again, when we talk about the activation of platelets and the activation of the thrombin making clot, the coagulation cascade, remember, it's a process that's mediated initially by platelets, and then it progresses. So platelets are always at the center of the action, right? And thrombin, which is factor 2A, plays a very important role in all these areas. So one of the things I want you guys to keep in mind. So when we're having issues that are preventing thrombin from being made, that's going to give us more bleeding tendencies. So again, something to keep in mind. Next slide. Okay, so when thrombin binds platelets, it actually changes the shape of the platelet and the platelet becomes activated. Now, the other important thing here is if we don't have enough circulating thrombin because the patient is using up the thrombin in, let's say, a DIC type of a picture, disseminated intravascular coagulopathy, where the products are being consumed because we're trying to make clot either appropriately or inappropriately. Then what happens is available, even platelets won't function properly. So we have to think about the availability of thrombin in these processes as well, not just clotting, but going forward. Next slide. So remember, fibrinogen mediates platelet adhesion and aggregation. So fibrinogen levels extremely important. In fact, because fibrinogen is so important, um, we need to really focus on fibrinogen levels in all our perioperative patients. So when we're getting that immediate ICU admission labs, we need to be thinking not just about PT, PTT, INR, but also fibrinogen level.
Hello,
We need to check that. The other thing
hello,
is remember factor 13. For those
hello,
of you that have reviewed coagulopathy from before, factor 13 is an addition. This is clot stabilization factor, and what this does is what you'll see in your patients is if there's a deficiency of factor 13, what happens is these patients will clot initially and then continue to bleed. So what you'll see is initial clot formation, but then they start bleeding again. So it's something that we have to be cognizant of and watch carefully. So very important there. Next slide. Okay, so you can see how the platelet plug is being made with just fibrinogen and platelets. Now, you'll notice that there's no, I mean, this type of clot is called white clot because it's only platelets. There's no red cells trapped in there. So initially, when we're seeing this type of clot, um, if we take measures that will block platelet activity, either using aspirin, clopidogrel, or any of the P2Y12 inhibitors, um, those will cause, again, bleeding issues, right? So again, platelet dysfunction issues have to be thought about. But you notice that the platelet is still the center of the clot. Next slide. Okay, let's go through the case. I mean, this is a 65-year-old male that complains of a right hip pain. Okay, they had a right hip fracture, and the patient was noted to be on aspirin and clopidogrel. Very common scenario, right? Because these patients have coronary disease, and the cardiologists love putting these patients on this type of thing, right? Now, the orthopedic team wants to take the patient for surgery. Now, here's the thing. As ICU management, you have to either talk to them about, if they're going to take the patient urgently to surgery, then you need to make sure that the patient is transfused platelets, because those platelets that are in the patient, even though the number is normal, they're non-functional. Because they're non-functional, the patient is going to bleed, especially because of the clopidogrel. The aspirin is not as much of an issue. Remember, either they have to wait 5 days to stop the clopidogrel and do an elective surgery, or if they're emergent, like this case, they need to give platelets. So platelet transfusion is necessary. Now, while there is very little data, um, the amount of platelets we need to give typically will give um, 2 units of um, pheresed platelets, so that that equals pooled platelets of about 12, a 12 pack. Okay, so that's how we have to give. So again, empirically, but again, keep in mind that that's what we're doing. So keep that in mind. Okay, next slide. Now, this slide is, I know, a busy slide, but I want you to keep in mind what the information here is. The information here is that most of these products that we talk about as far as coagulation is concerned are made in the liver. So if our liver function is abnormal, you may not be making these factors. And here's the other thing to remember: inflammation plus coagulopathy is much more problematic than just coagulopathy alone. And the reason for that is inflammation plays a unique role as far as coagulation issues are concerned. So you may get much more bleeding, you may get a hyperthrombotic state. So you have to watch your patient closely. So again, something to keep in mind. Now the other thing is look where what's not produced in the liver. Factor 3, which is tissue factor that's outside the vascular system, not produced in the liver. Factor 8 Willebrands, not produced in the liver. Now, the other thing I want you guys to keep in mind is vitamin K dependence, right? Because we use a lot of warfarin or coumadin in our patients that are coming in with acute trauma or head injury, or they're pre-surgical, right? So you need to make correction in their coagulation issues. By the way, the other thing, when we have a patient on clopidogrel or aspirin, you need to ask. You can't just stop it with indiscriminately. You need to ask the patient why they're on the clopidogrel. Now, if it's simply for coronary artery disease, okay. But if it is for a stent, if they have a stent in place, um, then you have to ask when the stent was placed. If it is within 2 weeks, between within 6 to 8 weeks of when the stent was placed. Now, if it's a bare metal stent, 2 to 3 weeks, you have to leave it alone. If it is a drug-eluting stent, you're going to have to leave it alone. The clopidogrel has to be left on for at least 6 to 8 weeks. Otherwise, you may get stent thrombosis. So you have to keep that in mind. By the way, going back now, let's look at vitamin K dependence. Right, 2, 7, 9, 10, protein C, protein S. Right. So these are what we're going to talk about. And as we go forward, I want you guys to kind of keep that in mind. Next slide. Okay, so um, again, all the reactions again for coagulation. Now we've spoken about platelet aggregation. Now we're talking about coagulation issues, right? All that involves various factors getting up to factor thrombin generation, right? Generating factor 2A. So this is what we're going to talk about. Let's continue to the next slide. Okay. But you notice that either the extrinsic pathway or the intrinsic pathway. Now, the simple thing to understand is the intrinsic pathway is simply called that because all the components are within blood vessels. That's why we call it in. Um, Extrinsic is simply because factor 3 is outside of blood vessels, and because it's outside of blood vessels, it is considered extrinsic pathway. Now, which is more common? No, we talk about heparin all the time, but because that affects the intrinsic pathway, but really speaking, the extrinsic is the most common pathway that we use. Now, the common pathway, when what you see in the middle, is really the final endpoint. So again, something to think about. Next slide. But you notice the center of all action is still the platelet. Now, when we talk about PT, PTT, INR, right? Now, prothrombin time, which is PT, you deal with international normalized ratio. And the reason for that is when we did the control values, that is, when the lab is testing the assay, in different hospitals, let's say you're working in psych care, and you're looking at the coagulation parameters there. The control value for PT may be different than at um, Prem Hospital. So the reason we do INR is simply looking at PT gets to be problematic. So again, something to keep in mind. PTT, on the other hand, is looking at the intrinsic pathway, and that's where heparin really comes into play. Now, the other thing to remember is sometimes what you'll have is activated coagulation time. Now, remember, for PT, PTT, INR, fibrinogen levels, you need to spin down the blood and get the plasma and test the plasma, right? For T, you can use whole blood. So your result for ACT will come back right away. So if you're using heparin extrinsically, um, then that heparin will change the ACT level. Now, by the way, if you use sub-Q heparin or low molecular weight heparin, the problem is your ACT may or may not change. So you have to be careful here. So again, something to keep in the back of your mind. A lot of vascular surgeons will check ACT to, because they're giving intravenous heparin. They want to check the efficacy of the heparin they're giving, and they will check the ACT based upon that. So again, something to keep in mind. Next slide. How do we make fibrin clot, right? Again, thrombin cleaves fibrinogen into fibrin monomers, and then the clot is stabilized by factor 13. Now, if I have a deficiency of factor 13, now where is factor 13? It's in fresh frozen plasma, and it's produced by the liver. So because it's produced by the liver and it's in fresh frozen plasma, if I have a patient with liver dysfunction, I may want to transfuse FFP if I'm noticing that the patient is initially seem to be clotting. The hemoglobin stays, level for a little while and then drops. What you may be noticing is deficiency of factor 13. So keep that in the back of your mind. Next slide. Okay, so you can see how the clot is being made. Now, remember, as the clot is being made, our body automatically starts working on breaking down the clot that's within the blood vessel, right? The wall, collagen is being made so that the wall can be repaired while the clot is being broken down by fibrinolysis. Now, if the fibrinolysis runs amok, that's a problem for us. And where do we see that? Well, we see that in certain patients that have trauma, right? Especially head injured patients. Fibrinolysis may be problematic. So we have to think about that. If the patient is continuing to bleed, am I getting a primary fibrinolysis or am I getting into disseminated intravascular coagulopathy? You have to think about your differential diagnosis. So you're going to be thinking through all this. Again, as you're watching your patient, I want you to think closely about this and I want you to watch how the patient is doing. Next slide. Now, how do we keep the coagulation system from inadvertently or inappropriately making clot, right? Kind of makes sense, right? The body has defense mechanisms, and the defense mechanisms are very important because inflammation, whether it be pneumonia, whether it be trauma, whether it be surgery, what it does is it takes away those intrinsic pathways. So, if I were to ask, does walking help these patients, protect them against clot formation? Depends. Um, if it is very minor surgery, not an issue. Ambulation is very good, no problem. But let's say a hip fracture patient that was repaired, uh, and you'll see this in India all the time, unfortunately. Um, we see patients that have a hip fracture. What happens? The hip fracture surgery is successful, patient does okay initially, and 2 weeks later, the patient is dead. Operation success, patient died. What happened? Pulmonary embolism. Why? Because the patient was not properly prophylaxed for the development of DVT and pulmonary embolism for a long enough period. So we'll talk about this. Next slide. Okay. So key points are the endogenous anticoagulation is very important. And remember, endogenous anticoagulation is impaired by inflammatory mediators. And so anytime you have a severe pneumonia, that patient needs to be prophylaxed for DVT. Makes sense, doesn't it? Even if they're walking around, if they have a severe pneumonia, it's a major problem. And if they're elderly, it's also a major problem. So you have to think about that. And again, platelet activation, all these things that happen. Uh, Remember COVID? I mean, we used to see platelet activation happening inadvertently, right? These patients had elevated D dimer levels. What was going on? Clot was being made inappropriately. Then we thought, okay, pulmonary embolism, I have to anticoagulate these patients. So again, think about what we're doing as we're looking at these patients. Next slide. By the way, D dimer levels are elevated in most post-surgical patients because clot is being made and broken down, right? So a D-dimer level in a medical patient is much more important from my decision tree than a D-dimer level in a surgical patient. In a surgical patient, I expect it to be elevated. Or in a trauma patient, I expect the D-dimer level to be elevated. So elevation of D-dimer in a surgical or a trauma patient doesn't give us much information. It just tells us clot is being made and broken down. And then for that, I just simply say, so what? Because it's a surgical patient. You expect it. Now, endogenous anticoagulation that we have, you know, utilizes heparin, which is intrinsic. Now, remember, intrinsic heparin that we have in our body is bound to the endothelial cell membrane. It is not freely circulating, but it follows the same principle as heparin that we give exogenously to our patient. It works through antithrombin 3, and we'll talk about that in just a second. Okay, antithrombin 3 is the next one. Prostacyclin, PGI2, is produced by endothelial cells and helps prevent coagulation cascade from going off. Protein C, protein S, we'll talk about how they work in just a second. Thrombomodulin, we'll talk about that also as well. Now, tissue factor pathway inhibitor and protein Z are membrane bound issues that protect against activated clotting issues. So they help us keep those inadvertent clots from happening. Okay, next slide. Okay, so let's look at what happens. Okay, so when um, heparin is which is membrane bound binds to antithrombin 3, what happens? It takes out thrombin, it takes out factor 10A and factor 9A. So because it does that, you do get any inadvertent activation of the clotting cascade is taken out by the body's own intrinsic protective systems, if you will. Now, how do protein C, protein S work? Now, remember, protein C and protein S are produced by the liver, right? But they're absorbed by the vascular endothelium. And then what happens? Well, thrombomodulin and thrombin work with protein C and protein S to create activated protein C, which takes out factor 5A. Okay. And normally produced factor 5A is taken out by activated protein C. Okay. However, now, what about patients that have, let's say, that develop clot and they have no underlying risk factor? Let's say you're looking at a patient and they just developed a DVT and you can't figure out why they developed the DVT because they don't have a pneumonia, they don't have systemic inflammation, they weren't in trauma. So, why would they develop it? Well, they would develop it if there was an intrinsic thrombophilia, right? And how does an intrinsic thrombophilia happen? Next slide. Okay. It can be a familial thrombophilia, like, or an acquired thrombophilia, like lupus syndrome, or there are different types, and I don't have to tell you guys that review medicine. I mean, you guys know this. Uh, but factor five Leiden is something we learned about, and factor five Leiden is a mutation of factor 5A, and when it's mutated, either by a heterozygote form or a recessive form, either way what you get is a thrombophilia. and these patients are at higher risk for developing DVT and pulmonary embolism. So we have to keep watching these patients closely and keep them on anticoagulants. So again, if you have such a patient, the question always arises, um, after surgery, how long do I need to keep somebody on an anticoagulant? Well, you need to keep them on at least, if it's major surgery like hip or knee surgery or orthopedic type surgery, you need to keep them on anticoagulant for 6 weeks. If they had major intra-abdominal surgery, 6 weeks anticoagulant. Now we have the advantage of the newer oral anticoagulants, and I'll talk about that in a little bit. But I want you guys to understand that we are talking about, how long we actually have to send these patients home with things like a Pixaban. So we'll talk about that in just a second. And we've learned this over the last 5-10 years. Next slide. Okay. Now, when we talk about protein C, protein S, and antithrombin 3, all these are produced by the liver, by the way. So if we have liver dysfunction, you can have a problem with either thrombosis, or you can have a problem with clotting, either one, right? So you have to think along those lines. And if you have a protein C or protein S deficiency, these are the patients that if you put them on Coumadin, you can necrose their skin. Because initially, vitamin K depletion works on these areas first, and then it works on coagulation factors. So vitamin K depletion is problematic. When we use Coumadin, you have to put them on some form of a heparin or a heparinoid or something of that nature to protect them for the first 2-3 days. So again, something to keep in mind. Now, if I'm giving heparin IV and I'm not seeing the effect that I want, and remember, timing is everything, right? Every 6 hours, the half life of heparin is about 90 minutes. So 4 half lives, 6 hours, needs to be weighted in order for you to get to a steady state. So you get your baseline PTT, and then you say, okay, I'm on a heparin drip. I need to check the PTT in 6 hours. So when you check it in 6 hours, if it's not working, you go up a little bit on the dosing, and then you see what happened, right? And again, the thing is steady state level, right? You're always thinking steady state level. Now, if it's not going up, the most common reason why heparin doesn't work is because antithrombin 3 levels are deficient. So remember that. So whenever I have that, I always think, okay, I need to give fresh frozen plasma because fresh frozen plasma has antithrombin 3 in it. Kind of seems paradoxical that I would give fresh frozen plasma to get the PTT to rise, but it is true. That's how you have to think about it. Next slide. So again, antithrombin 3 is also produced by the liver. Keep that in mind. So if you're trying to anticoagulate somebody, keep that in mind if heparin is not working, the number one reason. Next slide. Next slide. Okay. Now, here is that question, right? You've got a 45-year-old male noted to have a DVT for which he is on IV heparin. After 18 hours, that is several rounds of testing, you've noticed that the heparin drip is now at 1,500 units, which is pretty high, and the PTT is normal. The most appropriate management here is give fresh frozen plasma, because that will replace your antithrombin 3. And you don't need to give many units, just 1 unit of FFP will solve your problem. So, something to keep in mind. Next slide. Okay, now here is the thing about patients who are having, and this is why in perioperative patients, I routinely get cardiac enzymes on everybody. Even if the ECG is normal, they can still have a type 2 STEMI, right? It's not a STEMI, it's an N STEMI because the ST elevation is not there, but it's a type 2 MI. It's a demand type of issue, right? So a lot of postoperative patients, what happens? Their systolic pressure goes up because why? They're in pain, right? Their heart rate goes up. Why? Because they're in pain. These things tend to increase myocardial oxygen demand. If they have a fixed supply, what happens? These patients are at risk for developing ischemia, right? So, what do I need to do? I need to check enzymes. If the enzymes are positive, let's say troponin is positive, in that case, what I have to work on is reducing the heart rate, especially the heart rate, and reducing the systolic blood pressure so that I can control both and I can control myocardial oxygen demand. The other thing we need to do is in these patients, the target hemoglobin is not 7, but the minimum hemoglobin that you need is 10. So in these patients, if the hemoglobin is 8, you're going to have to transfuse them up. So that's the question here, right? You got a 65-year-old male patient that's involved in an MBC, um, shown to have elevated troponins. He's having an NSTEMI, right? So in this patient, right, what you need to do is transfuse the patient so they're no longer anemic. You have to get them over hemoglobin of 10. So think about that. Next slide. Okay. Now the fibrinolytic system is also an issue. Now remember, D dimer is a marker of clotting happening. All right, clotting and breakdown, right? It's a marker. So again, something to keep in mind. But plasminogen levels climb as we get into ischemic states. So keep that in mind. So again, something to keep in mind. We'll continue on. Keep going. Next slide. Okay. Perioperative issues, right? Low fibrinogen levels. Now, this was a recent amount of data that's come up over the last 5 years. Um, and this was out of both the UK and the United States. What they did was they looked at fibrinogen levels that were moderately low. And these patients, what they did was they looked at thromboelastograms. TEG is something that is being used more and more. Now, we don't have it in India, but the issue that it brought up was if fibrinogen levels are even moderately low, they don't have to be extremely low, but even if moderately low, the ability to make clot and sustain clot is problematic. So, something to keep in mind. So, you want to check fibrinogen levels, and if the fibrinogen levels are even moderately low, then you go into if they're even slightly on the low side of normal, you may have to transfuse cryoprecipitate. Remember that. Don't forget. Next slide. Okay. So as we think about fibrinogen levels, now remember 2 to 4.5 grams per liter is the threshold. If you're between that range, it's associated with an increased risk of bleeding. So keep that in mind. Even if they're seemingly normal, because two, is pretty close to normal. 2 grams per liter is pretty close to normal range for most fibrinogen level, but yet there is increased bleeding. You really want to think about transfusing cryo in that setting. So keep that in mind. If your patient is bleeding or their hemoglobin is dropping even slowly, keep that in mind. Next slide. Okay. Now I'm going to talk a little bit about the newer oral anticoagulants. Now, there are 4 of them that are in the marketplace. A couple of them are very expensive. You're not probably not going to see them, but apixaban, I will point out, is very cheap, and you'll be seeing a lot of it. Okay, in India, it's very cheap. You can actually get it very, very reasonably. These are all, by the way, these are oral drugs. So again, PO medications. So the patient may be on it. You have to ask. If you're trying to reverse the use, you need to understand why they're on it and can you reverse it? Do you want to reverse it? So we'll talk about that. Dabigatran, let's start with that. Next slide. Okay, dabigatran is a direct thrombin inhibitor. Because it's a direct thrombin inhibitor, it is a problematic issue because if you give FFP, it won't fix it. If you give prothrombin complexes, it won't fix it. You have to use Predexbind, which is a monoclonal antibody that has it's its own reversal agent, right? So you have to use Predexbind. It is available in India. You can use it, but dabigatran is one of those drugs you have to be very careful with. Okay, next slide. Now, rivaroxaban, apixaban, and indoxaban are all 10A inhibitors. Because of that, you can use prothrombin complexes or FFP. Now, vitamin K will not help you here. This is not a vitamin K correctable issue. So, again, if you need to reverse, you have to think about that. Again, these are used for DVT therapy and prophylaxis, so keep that in mind. Be real careful here. Next slide. Next slide. Okay, apixaban we already spoke about. Endoxaban, same thing. Next slide. Okay, warfarin. Now here's with warfarin. Now warfarin works by vitamin K. Now you can, in the old days, we used to say you can't give vitamin K IV because of anaphylaxis and all that. We found that that's not true. Okay, you can give vitamin K IV. Okay, if you want rapid reversal, you can give vitamin K IV. My suggestion is repeat the dose a couple of times because giving one time dose doesn't help you. So you need to give it every 8 hours or so and reverse your thing. But also give FFP. Don't forget, give FFP, please. Make sure you remember to do that. So again, um, and if you're reversing, you can use prothrombin complexes, but really speaking, um, vitamin K and FFP do a pretty good job. Prothrombin complexes are much more expensive. That is, prothrombin complex, if you think about prothrombin complexes, what is it? It's factor 9A being provided. So again, keep that in mind. Okay, next slide. Okay, again, um, anticoagulant effect lasts longer with warfarin. So you have to keep redosing your vitamin K and keep redosing your FFP. So please remember that the duration of time of activity of warfarin in the circulation is much greater than that of your transfusions. So you have to keep up the transfusions. Now, here's the other thing about transfusing. Now, um, we all learned in histology and pathology that red blood cells hang around for a long time, 120 days or something like that. But remember this: when you give red blood cells that are in blood bank, life is much shorter. So every couple of weeks, those cells are going to be broken down. So they're not going to last 2 months or 3 months. That's not going to happen. So you got to remember that. So when you're giving blood transfusions, also remember you need to put traits on these patients like iron, B12, folate, etc., so that the bone marrow itself can start producing. So give those substrates. Very important. So don't forget to do that. Next slide. Okay, what else do we have? Again, the first step, always again think about macrovascular bleeding. I know the surgeon's going to deny it, right? Anytime there's a blood loss going on, patient's hemodynamically unstable, call the surgeon and say, hey, where's the money? If they operated in the belly, it's probably in the belly. So you got to tell the surgeon, come back and have a look. Okay, I'm being a surgeon myself. I can tell you. Okay, my first response: oh, it's not bleeding in the belly. Of course, it can be, right? I mean, this is the thing. I mean, they're going to say, oh, it's probably no, it's probably macrovascular bleeding. Please have a look. Okay, so very important, especially if it's early on after surgery. And here's the other thing about fibrinolysis. Now, you know, you'll notice oftentimes the patient will keep bleeding until the clot in the abdomen is evacuated. Now, they won't find an active source of blood loss. But what happened? The substrate is there and you're getting primary fibrinolysis. So if they re-exploration, they evacuate the clot and the surgeon says, oh, you see, I told you there is no bleeding vessel. It's primary fibrinolysis. And guess what? By evacuating the clot, you fix the problem. So again, something to tell the surgeon and say, please, next time, don't ignore us. Go in and do that for us. Then now when you're thinking about microvascular blood loss, okay, so again, think about restricting the amount of crystalloid and colloid like albumin that you're providing. Also think about providing the other products, FFP, cryo. These products are absolutely necessary. You need to give FFP, you need to give cryo. And again, massive transfusion protocol, we have a thing in radar. I put it there. So we have that. So all you need to do is take the massive transfusion protocol checklist and just go right down the checklist. Make sure that they're just not giving packed red cells. If they can get whole blood, great. If it's a trauma and they're losing blood, whole blood is a very reasonable option in that population. It's hard to get because we don't typically get whole blood bank. But in India, you have an advantage. Whole blood is available. So if you got a trauma patient or something like that, whole blood is not an unreasonable option. And if the surgeon wants to give whole blood, say, by all means, do so. Next slide. But remember, again, cryo for fibrinogen levels and factor VIII von Willebrands. Okay. Now, let's talk a little bit about case-specific issues. In cardiac and vascular surgery, which you're going to face, not cardiac necessarily, but vascular surgery, again, you do get increased blood loss with either cardiopulmonary bypass or just post-vascular patients. These patients tend to bleed. Okay, so please remember that. Keep that in mind. The other thing is if you put them on ECMO, I know we're going to be working some ECMO centers. ECMO can increase, the longer the patient is on ECMO, the increased risk of bleeding is there, microvascular bleeding. So you're going to have to put these patients on massive transfusion protocol after they come off the ECMO. So you're going to have to keep chasing. So again, something to keep in mind, okay? And again, both plasma and cellular products are affected. So keep that in mind. Platelets are affected. You're going to have to transfuse platelets. Platelets will become abnormal. Even though the number will remain fine, the activity of the platelet will be abnormal. So you may have to transfuse platelets. Please remember that. Next slide. Okay, in trauma, remember also, okay, again, if you're transfusing large amounts of fluid and blood products, okay, again, these patients are susceptible to having coagulopathy, right? Even without the transfusion, even without the fluid resuscitation, about half of your patients can be coagulopathic just from the trauma itself. Remember that. So when you're dealing with trauma, always check your fibrinogen level, check your PT, PTT, INR, make sure that you know where they are. Okay. If they're not actively bleeding, I don't need to correct. If they are actively bleeding, I have to start my correction. And remember, my correction is not predicated on the blood levels. It is predicated on the patient stopping bleeding. Very important. Next slide. Postpartum, and you're going to see this a lot. When you see postpartum hemorrhage, okay, these patients will have tons of bleeding, and oftentimes postpartum hemorrhage is underestimated by our obstetric colleagues. Okay, it's just like the orthopedic surgeon saying, if you ask him what the estimated blood loss in surgery was, oh, he say, oh, maybe we lost 10, 15 ml. Come on now. When you make a skin incision, you lose 15 ml. So don't tell me that. So again, keep that in mind. Okay. So when you're managing the perioperative patient in the postpartum hemorrhage, okay, always think, is it macrovascular? Is there retained products and so forth in that uterus? Or is it microvascular? And do I need to put them on a massive transfusion protocol? So make sure you think about it. Remember, primary fibrinolysis also takes place in these patients. So you have to think, how am I going to correct that primary fibrinolysis? Do I want to use epsilon aminocaproic acid? Do I Amicar, right? So do I want to do that? Do I want to give other types of anti-fibrinolytic products so that I can protect against bleeding? Do I need to do that? You have to think about that. Next slide. And again, the issue here is fibrinogen deficit is very problematic. And what corrects it? Cryoprecipitate. You have to give cryo. So make sure that the blood bank is aware. Give them a heads up. Um, Here's the other thing that I notice. When patients get into bleeding, everybody says, okay, we're going to write the order for transfusion. Give the blood bank a heads up. Tell them what's going on. Tell them that they need to prepare for 10 units, 12 units. They need to prepare. If they're not ready, you're going to have a problem. And that's the issue. And remember, the longer the bleeding goes, you're going to be transfusing more. So the earlier you transfuse blood products, etc., your effectiveness will be better. So be aggressive early. Don't wait. Don't say, oh, I'm going to wait for the hemoglobin to drop below 7. Because if you wait and the patient is bleeding, by the time they get to 7, they're going to go real fast. Okay. And that's the problem. Next slide. Okay. Let's talk a little bit about drug-induced coagulopathy. When you're looking at drugs that they're on, make sure that you go back through and reassess. Next slide. Okay. When they're on antiplatelet drugs, now remember, if they're on P2Y12 inhibitors, ticagrelor, prasugrel, uh, clopidogrel, this is going to affect the platelets lifespan. So you have to start transfusing platelets, and you got to give at least two ferrous platelet units, minimum two. Start with, and you may need to repeat because the platelet functionality may not be that long in the platelets that you're transfusing. So you have to think about that. Okay. So again, get ahead of it. Okay. Delayed discontinuation of your medications may give you more bleeding. So that's the other thing. Reversal, you're going to have to decide risk benefit issue. So again, keep that in mind. Next slide. Now, again, current recommendation is keep the platelet count above 50,000 if you're on if you're planning a procedure. If they're actively bleeding, get them over 100,000, please. Okay. Make this your rule. That's the current recommendation from various hematologic societies. This is the way to go. Next slide. Okay, let's go through the next case. Again, 62-year-old male transfused 1 unit of packed red cells, and the transfusion, the patient is noted to become hypotensive. This is a very classic presentation. ABO intolerance, right? ABO issue, right? So what do I have? I have a transfusion reaction. Now, what do I need to do? Okay, stop the transfusion, number one. Okay, so it's very important. One, stop the transfusion. After that, it's all supportive care. But stop the transfusion for heaven's sake and send it down to the blood bank let them go through their battery of tests. They have a battery of tests they have to go through. So let them go through that. But it is a clerical error that caused the problem. So if that happens, you have to check by performance improvement measures. You have to check every time, where was it missed, what happened, so that it can be corrected so it doesn't happen again in that institution. So be careful. Heparin does not help. Steroids do not help. Again, and do not, for heaven's sake, do not continue the transfusion. Okay. So very important. If they have a fever during transfusion, that's a transfusion reaction. Stop the transfusion, send the blood back, let the blood bank do their battery of tests, and then if you have to transfuse later, once the temperature is back down, get another unit and transfuse. Do not continue the same unit if they spike. Remember, it could be a transfusion reaction. Next slide. Okay, so summary. Coagulation parameters need to include fibrinogen level. This is a change. It was not the case 10 years ago, but now, because we're learning so much about how fibrinogen is acting in the process, you need to check fibrinogen level. History needs to be checked for antiplatelet drugs and anticoagulants. So you need to know, okay? And again, the next issue, again, need to balance risk versus benefit, and you need to check again, why are they on the medication. If they're on the medication because they have a stent, for heaven's sake, talk to the patient, talk to the doctor, and let everybody know. Okay. And again, by the way, we talk about sequential compression devices, right? The pumps, right? The most recent advice, the American College of Chest Physicians, which is the leading organization as far as guidelines for DVT prevention and pulmonary embolism prevention. You know what they say about surgical patients? SCDs have minimal, if not zero, effect on surgical patients, and they may not have much of an effect on medical patients. Although in medical patients, the data is still coming back, but at this stage, that's something to think about. Now, if anticoagulation is contraindicated, then obviously you have no option. That's the best you can offer. However, if it's not contraindicated, think pharmacologic agents for DVT prophylaxis. Please remember that, especially in perioperative patients. And you can start your heparin sub-Q or low molecular weight heparin sub-Q right off the bat after surgery within 12 hours. I mean, you don't need to wait. In fact, even the 12 hours is because it's to appease the surgeon, because they're worried. Okay. But the data would suggest that it doesn't seem to matter. So again, something to keep in mind. Okay. So again, please keep that in mind. Next slide. I know I went really fast, but a lot of material. Please review. Any questions?
Thank you, Akella. That was good. Dilip, there are a few hands up here. Can I go
Okay.
in and out?
Yeah, let's take the other questions. I just have a couple of comments. A fantastic talk as usual.
Yeah. So we had an Arjun Mishra who had put up his hand. He's not on the meet at the moment. Genpure Gangs had a question.
Pushpa.
Dr. Genpure Gangs had a question. We'll come to this.
Dilip, what was your comment?
Hello.
Oh, go ahead, Pushpa.
Okay.
I'm Dr. Niti speaking on Pushpa's number.
Okay, Nikhil, how are you?
I want to ask, I'm a surgeon. I'm Dr. Niti.
Yes. Hello.
Hello. Sir, just one
Yes,
question.
okay.
We made a session on damage control surgery, sir. Damage control surgery. And the other thing is the role of hypothermia. The hypothermia can aggravate
Indeed.
bleeding. So I had a experience that when we a lot of temperature near about 80, blankets and that can act. So bleeding.
Yes,
So
hypothermia
appropriate
is
temperature
very
setting and
problematic if it's
hypothermia.
below 35.
The role of hypothermia in exercise.
See, below 35 centigrade, it's problematic.
So I had experience. Yes. So
And the thing to remember is because we see
paramedics are also, I think,
hypothermia, we use hypothermia temperature targeted management of post ROSC patients, right? So in those patients, if you start seeing bleeding, you're going to have to back off the hypothermia. You can't help it because you have to control the bleeding.
yes. And our damage control surgery, if you're dealing with any abdominal trauma, we can pack the abdomen, close it, and wait for a while, open up afterwards.
Yes, I mean, and
So that also message
is open packed. You need to keep talking to the surgeon about macrovascular bleeding as well as micro. Because here's the thing, even when they pack, sometimes little blood vessels will open up. And you need to keep that conversation going with the surgeon and say, the number one thing is always macrovascular. The second thing that they can help with is the issue of being able to evacuate clot and remove substrate from fibrinolysis. So something to keep in mind.
Thank you.
Yeah. Any other questions?
Dr. Amar.
Hello, hi. Very good presentation, Dr. Akella. I'm an anesthetist running an ICU in a remote area in Rajapalayam. I have practicing privilege in UK as well. Recently, I was in UK in a cardiac center. They have started using fibrinogen recombinant fibrinogen, and they also have recombinant antithrombin free. So,
Yes.
so as you said,
Fibrinogen concentrate is now being made available. But again, in India, the thing to use is cryo.
It is expensive even in UK hospitals. Not all hospitals have it. But
Yes,
for
I agree.
Yeah, but for certain, we can stock it up and have it, in emergency, like snake bite and other conditions where the blood bag is not nearby. It is in a remote area. You can't have it's very difficult to get it. I'm just thinking for those small hospitals.
Yes.
I think Thank you very much, Dr. Akella. Very good presentation.
Dilip.
Arjun was back on the mic.
Thanks again for the presentation. Just a couple of quick comments. See, many of our partner hospitals and even areas we visit, they're doing bleeding time and clotting time as screening tests. I think, having spoken to multiple hematologists also, I think this is the right time to maybe, start saving money for our patients as well. Because if we are anyway going to follow up with an INR and APTT and a platelet count, a bleeding time, clotting time has no value. And regardless, the positive predictive value of those two tests is, 70 years old now, and we can safely abandon those tests and just rely on these newer tests. So that was one comment.
Absolutely. And bleeding time, we've abandoned it a long time ago.
Exactly.
And same with clotting time. I mean, I think we need to stop that.
Yeah, so let's stop that at whatever. I know it's a cheap test, but why do it if it has no value? So I think
Correct.
that ship we can move on for all our hospitals. I think that's a good sort of a performance improvement thing that we can do. The second point I wanted to make was exactly what you said. You use this term of performance improvement, and I just want to share this and make a plug for everyone on the call. We can do this for each ICU that we are working with, where we can institute these performance improvement policies and take it on a case by case basis. Whatever individual problems are there, we can target it with a performance improvement plan, and then over a 3 to 6 months period, see what we can do for these individual problem statements on a case-by-case basis. That was the second point. The third one was interesting. What doctor was just mentioning about the UK drug availability on antithrombin as well. I think what will probably happen in the next 5 to 10 years is we will become more and more targeted for our approach to not just periop coagulopathy, but coagulopathy in critical care in general. For example, the test that I'm talking about specifically is thromboelastography. Thromboelastography has a critical role in complex coagulopathies like you would see in a liver disease patient pre-transplant, for example. But from the concept of the test itself, it's actually a very, methodologically sound functional test. It tells you which part of the coagulation cascade has a problem and then allows you to target the intervention to that part of the coagulation cascade. Now, it's not easily available. Most transplant centers have it. Cardiac centers have it. But I think as the utilization increases, we will have a more targeted approach to see. So, for example, if you do a thromboelastogram, you'll know if it is a platelet problem or a fibrinogen problem or a cryo problem that you need to intervene on. I don't know when that will happen, but I suspect these will get a little bit more precise as the availability of these tests improves. So that's it. Those were my 3 comments.
I agree. The only thing is that it's going to take some time to get TEG in here.
Yes.
I do have a whole talk on TEG, but the thing is that since it's not available, I kind of backed off on that.
Yeah.
But you're
it's a
absolutely
fantastic test. Yeah, it's a really good test. It's a
awesome.
test that, yeah, exactly. So,
And even the interpretation is not as complex as everything else.
Oh, it's very straightforward, by the way. Sashi, it's very straightforward. I've done it many a time with trauma patients, so it's something that's very useful.
Fantastic talk, Akella. I've got just one comment and a couple of actually discussion points or questions. See, one is trauma in terms of the tranexamic acid being used left, right, and center. We might need to think, although there's no complications of tranexamic acid and the evidence is purely within the first 3 hours. It's okay to give, but giving drugs which are probably not useful may not be there. Because many times we do see these drugs given for the next 3 days, 4 days after trauma or any major bleeding.
Yeah, you don't need to. If the bleeding is stopped, there is no need.
And in the early phases, it's the most useful and outcome benefit. So that is one point. The second thing is, can you actually, I've always had doubts about hemolysis in post-surgical bleeders as a cause, especially in patients like cardiac patients, for example, or I don't know, even obstetric bleeders with hemolysis, not the regular viral diseases, etc., which causes hemolysis and bleeding. Do you have any thoughts on that?
Hemolysis. Remember, once you start getting intravascular hemolysis, fortunately it's rare. You'll start seeing a deterioration in kidney function very rapidly, much more rapid than just blood loss issues. So you really need, if you're getting intravascular hemolysis, you're concerned about it, you need to think back to the blood transfusion, and you need to get the blood bank involved in the testing and everything. So again, the blood bank has to be an integral part of what you're doing there. So that's going to be important. You have to, but again, supportive care. There is no additional therapy.
No additional therapy. That's right. And the second point I wanted to just highlight or bring in is, when we do have in trauma or major bleeders and major transfusions, a complication of getting the DIC, and fortunately on the DIC is a bleeding problem, they do have microvascular thrombus formation, for which heparins are quite well indicated. There's always a 50-50 school of thought in terms of using heparins or not for DIC. What's your thought on it? Do anyone have comments of use of heparin on in DIC patients?
I think he's mute for a second.
Akella, I think you're mute.
I guess while he answers, the usual take on heparin and DIC is if you're bleeding, no heparin. If you're clotting, heparin. That's what most guidelines say.
But again, I think We don't use heparin routinely. With DIC, what we focus on is source control, and get on that.
So on a practical terms, if you have, even though you have evidence of DIC and no bleeding, there is a possibility, and you're given all that space, you're given the products, etc. You can give a low dose heparin infusion to prevent the microvascular thrombus. If there is bleeding, then you don't do that. That's the.
I don't think there's a prophylactic role, Shashi. I've not seen. I've seen case series and many data sets on it, but there are no society-based guideline recommendations on prophylactic heparin in established DIC. That I'm confident of.
More than prophylaxis, I'm wondering about, look, you have this DIC which is established, but you're unable to get reversal of that despite as much as possible source control in terms of having the lab numbers abnormal.
Correct. So I'll give you a practical example. Let's say you have DIC, your platelet count has trended down from 1.2 lakhs to 80,000. And you have picked up telltale signs of DIC where your fibrinogen is also. At this point, I would just continue prophylactic heparin by published standards for DVT prophylaxis. I would not do an infusion. The moment my platelet threshold goes down, let's say below 50,000, I would stop the prophylactic heparin because there is a bleed risk. So it's going to be a moving target because DIC evolves over a 10-day period anyway. I wouldn't, for example, if the platelet count was, 40,000, I wouldn't change to a heparin drip just because of a diagnosis of DIC.
I think we have to be careful about using, a drug like heparin. We have to be cautious about how we want to utilize it and where we want to go with that. Again, prophylactic, not really indicated. So something to keep in mind.
So DIC is not a single disease, right? We don't understand the exact complex pathway here. Here again, a test like a serial TEG will tell you which pathway is actually deranged. So for example, if you take a DIC patient, and we've done this when we used to do transplants, we would diagnose DIC, but if you do a TEG, it's not like they are, they're not prothrombotic in certain phases of DIC. So you don't know which phase you're attacking the patient. So similarly, in a liver disease patient, if you do a TEG, you may find that they are prothrombotic even though their INR is 2.5. So I think there is not much that we can tell just by a platelet count in a DIC or just by a, I think we have to look at the entire stigmata and then take a call on what we can treat when there's a defined endpoint, like an actual clot or an actual bleed. So I think that is the key in DIC, because DIC is more like a more superficial representation of the entire coagulopathy cascade with individual bits and pieces visible to us. We don't have a test other than TEG that can tell us these individual moving parts of a DIC patient.
I agree. And I think that, again, I think TEG, that's where TEG's advantage really comes. Again, I think understanding, I think TEG is much more useful for ICU than it is for even trauma, because the issue here is that it allows us to go through the differential diagnosis as to what's going on and where the problem exists, much better than just coagulation parameters.
Maybe the next talk can be TEG and ROTEM. It's fascinating.
Absolutely. And ROTEM is interesting because TEG and ROTEM are not the same thing. They're a little bit different. And it turns out, at least in trauma patients where both are being looked at, it turns out that TEG is a little better. Our guys are able to interpret it a little bit more cleanly. And I think that's the issue with differentiating between TEG and ROTEM. So it's an interesting issue that's coming up. But again, I think that technology where we're looking at clot and how clot is being made is vital.
Sorry, it might not be a question of, but I thought TEG is just the actual vial spins, and in ROTEM the pin spins. That's about what it is.
Yeah, but it turns out that there is the way the information comes out and the interpretation of the diagrams. It seems is easier with TEG than it is with ROTEM. So that's where people have kind of said, perhaps TEG is better from that perspective.
Dr. Ramamurthy had a comment or a question.
Thank you for the nice talk, Dr. Akella. Yeah, I think TEG is very good. I worked recently in a center which used ROTEM. ROTEM is very expensive. One ROTEM test will cost 400 pounds. It's very expensive in UK standards. It's very easy to operate. That's the only advantage of ROTEM. Anyone can operate, but TEG needs more, expertise to put the cups and everything in the proper setup. So, but ROTEM is very foolproof. Even an anesthesia technician can operate ROTEM. That's the only advantage, but it's very expensive. TEG is cheaper. TEG is cheaper. As you all saying, the ROTEM and TEG has changed the coagulation picture. And I've spoken to cardiac anesthetists, and they as soon as the patient comes up for cardiac surgery, the only test they do is a ROTEM or a TEG, and based on that, they give the transfusion, FFP or cryo or fibrinogen or platelets. So it's the things have changed in cardiac surgery settings. And Dr. Dilip, one request: this transfusion reaction can be, if you could support our hospitals in preventing transfusion reaction, that would be a big, performance support from your side. Both, in terms of management, how to prevent it. That will be a good topic, I think, and we all welcome it.
We'll take that as a homework. Thank you.
Okay, thank you.
All right, guys.
Thank you very much, Akella. It was fantastic. Thanks everyone for participating.